Hi everyone. So this is going to be a fairly brief talk on hypertension, and I'm just going to try and get across some of the main points. I'm going to be doing a little series on some of the things that I'm studying at medical school. So I'm not by any means an expert. Some of these things might or might not be correct, so if anything you notice seems incorrect, just send me a message or comment on the video and let me know. But for the most part, this should all be um, up to date and relevant, at least in the UK. So, hypertension is an extremely important disease, which is fairly difficult to pick up if you don't actually screen for it, because it doesn't have many symptoms, but I'll go over that later, or it doesn't tend to have symptoms at least. So, it's one of the main causes of morbidity and mortality. Well, it's the leading cause. So, this is something which can lead to all kinds of problems. Um, Lots of cardiovascular problems. It puts you at risk for all kinds of stuff, so I'll go over those as well later. And it's directly and indirectly responsible for 20% of the deaths in the world. So it's very, very significant disease. In 40% of those that have a stroke, their systolic blood pressure is equal to or more than 140 millimeters of mercury. So it's obviously accountable for many of the strokes, or at least present in many of the strokes that occur. In terms of etiology, how hypertension comes about, in general, 90% of the time, in which case the hypertension is primary, it's not really fully understood how it comes about. In that case, at the moment, it's considered that it's caused by multiple multiple factors. One of them being age, and that's because our arteries tend to get stiffer as we age. For example, in the aorta, the aorta usually buffers the systolic pressure because of its elasticity when during systole, when the heart pumps out into it, and by expanding when the heart pumps into it, that sort of takes the stress of that higher pressure coming from the left ventricle and buffers it to a slightly lower pressure. As that becomes stiffer, it doesn't get as buffered, and you end up with a higher systolic pressure. You also end up with a higher diastolic pressure, so your pulse pressure will narrow as you get older as well. And that's because you don't have that same recoil from the elasticity in the aorta, which maintains the blood pressure in diastole. Those that smoke also have a slightly higher blood pressure. It can add around 20/10 millimeters of mercury to your blood pressure. That's 20 systolic, 10 diastolic. Weight, the more someone weighs, the higher their blood pressure. Physical and emotional stress can also increase blood pressure, and those are things you have to look out for when you are screening for it. If you take anyone's blood pressure, you have to really take it multiple times throughout the day, because on a one-off, it might just happen to be that maybe they're a bit nervous about having the blood pressure taken, or for some reason they're a bit nervous, or maybe they've just had an argument with someone and their blood pressure will be higher. So you have to take blood pressure over a long period of time in the day, and I'll go over exactly how to do that in the diagnostics slide. The environment around people can influence blood pressure, as can diet. If someone has high cholesterol in their diet, that can encourage narrowing of the vessel lumen around the body, and that can encourage hypertension. And our genes, a lot of hypertension is just based on inherited genes that relate to hypertension. So, renal disease accounts for a large portion of hypertension that's secondary. So, essential or primary hypertension, which is about 90% of hypertension cases, consists of all the different etiological factors that I went over, like age and diet and things. The other 20%, the resistant hypertension, 20% of that um, is renal disease. So something like renal artery stenosis can cause hypertension because the kidneys think that the blood pressure is low because they're not getting much blood from the renal arteries because they're stenosed. So they release renin and angiotensin and aldosterone, and all these things stimulate the blood pressure to be increased in the periphery. So then the kidneys continue to not get any increase in their blood supply. So that's just a vicious cycle of increasing blood pressure. So especially in the young and in those where hypertension seems to be an unusual finding, for example, people under the age of say 20 or in children, then it's often worth listening for bruits over the aortic arteries, over the renal arteries, or and if you hear a bruit, moving on to something like a renal ultrasound or renal arteriogram. Some of the major risk factors for hypertension that hypertension brings about really all relate to this high shear force when blood pressure is high and the blood is sort of rushing across the surface of the vessels and whatever's lining the vessels. So when there's any atherosclerotic plaques that are maybe slightly unstable, then the chance of those rupturing because of shear forces from the blood pressure being high is increased. So that means you're more likely to get a clot thrown off that goes off somewhere, or part of a plaque rupturing and going somewhere, and those can cause strokes, myocardial infarctions, renal disease and limb ischemia. But you can also get, because of the higher force, changes in the arterial walls, which results in things like aneurysms and dissections. And obviously all of those are very pretty deadly, so that's really why hypertension accounts for so much morbidity and mainly mortality. The symptoms in hypertension are actually pretty rare. It's unusual for hypertension has to be quite severe for any symptoms to happen, really. But if someone does have symptoms, the kind of things they might get are headaches, bloody noses, and the symptoms from end organ damage. And end organ damage just refers to the organs that are susceptible to damage via high blood pressure. And I'll go over those in a bit. Those are things like hypertensive retinopathy. So doing fundoscopy to look at the eyes, the kidneys, the heart, the arteries, ultrasound to see if there's an aneurysm and things like that. That's checking for end organ damage, and symptoms can come about because of that. There are not many signs either. You might notice papilloedema if there's raised intracranial pressure on a fundoscopy, and you might also find left ventricular hypertrophy, but that's probably not easy as far as I know, not easy to pick up as a sign, because the only way you'd really be able to tell that was from a prominent apex beat, unless you actually did an ECG or an echo. So this is more to do with the diagnosing of hypertension now, and there are 3 stages: stage 1, 2, and stage 3 or severe. Now, in the first stage, if you find someone that comes into the clinic and you just take a one-off reading that tells you that their blood pressure is 120/80 is basically the normal sort of considered healthy blood pressure, 120/80 or less. If it's between 120 if it's between 120 and 140 over 80 to 90, then that's considered pre-hypertension, which doesn't really need treatment but could be observed. If they get into stage 1 though, if you just measure one off in a clinic, someone's blood pressure, and find 140/90 or more, that doesn't necessarily mean that they have high blood pressure. You'd have to get several measurements of that blood pressure to actually be certain, and I'm not exactly sure how many it is in the UK system, but what we were told at in medical school was that you need a minimum of 30 readings to have a good idea of how someone's blood pressure is, and a maximum of 70. You need equal to or more than 14 readings in a day to actually get a decent idea of the blood pressure. And I say in a day because blood pressure increases at night, so by convention it just tends to be measured in the day. The ABPM is ambulatory blood pressure monitoring, and that's done over 24 hours with a monitor on the patient's arm that they take home, and it just inflates every now and then and checks their blood pressure, and that will do it several times throughout the day, more than 14 times, and then they will come back. You will get the data from the blood pressure ABPM machine that they've been using, and that's a much more sensitive test for high blood pressure. So if they have a blood pressure of 135/85 or more, but less than 160/100, then you can say that less than 150/95, sorry, then you can say that that person has stage 1 hypertension. And if it's 150/95 or more, then that's stage 2. And then in severe, this is the only one that's actually different, in severe, at any point that you measure someone's blood pressure and it turns out that it's 180 or more systolic or 110 or more diastolic on any one occasion, that's severe hypertension. So you'd just go straight to treatment as a result of that. So the end organ damage can show a few changes. Left ventricular remodeling, which you could see using echocardiography, you might get an idea of it from the QRS amplitude on an ECG as well. They probably have some diastolic dysfunction, so you might see increased left atrial size on echo, and I can't remember off the top of my head what that does to the P waves in the left atrium on an ECG. It's either a bifid P wave or a peaked P wave. One of them suggests the right atrium's large, the other one suggests the left atrium's large. Maybe someone can put it in the comments for the video, but I'll try and find out and put it in as a message on this slide, if I can. So, if the kidneys are involved in end organ damage, you might find proteinuria. If there's raised intracranial pressure, and this is quite a serious sign to find, you might see papilloedema on fundoscopy and retinopathy. So their vision might suffer, which could also be a symptom and a sign if they do end up with hypertensive retinopathy. So screening for these secondary causes. There are several secondary causes. More than several, there are quite a lot. These are some of the main ones that I've put down. Renal artery stenosis, like I explained, the kidneys aren't getting the blood from the rest of the periphery, and they think the blood pressure is low, if you can say that they think, and they obviously initiate the renin-angiotensin-aldosterone system and cause an increase in blood pressure through reabsorption of sodium in the nephron because of aldosterone. Cushing's and cons. Cushing's is a high level of cortisol in the body. So if someone has Cushing's, that can also cause more sodium retention through the kidneys. Cons as well. Sleep apnea can result in pulmonary hypertension, but also hypertension, also just general hypertension. So when do you actually treat hypertension? And this can be a bit difficult to decide when to treat it, but there's fairly specific guidelines on when. So if it's you don't just treat if someone's in stage 1 hypertension necessarily. If they're in stage 1 hypertension and they don't have any of these things I'm about to mention, then you can try to monitor them and suggest a certain diet. Maybe a diet with less salt in, maybe with low salt, which is potassium chloride instead of sodium chloride or something. So if you are going to treat though in stage 1, it needs to be stage 1 plus either of the following, and that's any end organ damage. So you find any end organ damage like what I've described, or they've got a 10-year cardiovascular risk of equal to or more than 20%. If it's stage 2 or severe, you always treat. So it's not too difficult to know when to treat, but you just have to make sure that you've assessed the end organ damage and the cardiovascular risk if it's stage 1. So the treatment, at first to me, the treatment seemed quite complicated, but actually it's not too bad. It gets kind of complicated when a patient is sort of at a childbearing age, and there are quite a few drugs like ACE inhibitors and aldosterone receptor blockers, which are contraindicated in pregnancy because of their teratogenicity. So that's a bit more complicated, but to begin with, if you've got a patient that's less than 55, all you really need to remember is ACD. And A stands for ACE inhibitors. That's the first thing you give to try to control the hypertension. If that doesn't control it, you move on to a calcium channel blocker. And if that doesn't control it, you move on to a diuretic. And the diuretic tends to be a thiazide diuretic. Because ACE inhibitors work based on renin, based on the renin-angiotensin-aldosterone system, where ACE converts angiotensin 1 into angiotensin 2, which then simulates the release of aldosterone. Because that works via the renin system, in people that are more than 55, the levels of renin in their kidneys, I think I'm right in saying this, is lower. So the drugs like ACE inhibitors won't have such an effect on those patients. So you start off on a slightly different regimen. And I forgot to put in here also that if they are, if they're black as well, or more than 55, then you use this regimen. The problem is that in those that are black, there's a risk of causing quite severe peripheral edema, and they don't tolerate so well the ACE inhibitors. So start off with calcium channel blockers instead, which can still do the job just as well. It's just a different line of drugs. So you start off with calcium channel blockers, then you move on to diuretics if that's still not controlling it, and then you do move on to ACE inhibitors, and then the final line treatment in those patients is beta blockers. So there are a few exceptions, like what I was mentioning in pregnancy. I don't know how I managed to spell start wrong there, but you start with labetalol. You cannot give ACE inhibitors or angiotensin or aldosterone receptor blockers in pregnancy because they're teratogenic. So you start with labetalol, which is an alpha beta blocker. If someone has an MI or has had an MI, has bradycardia or is in heart failure, you can't give them calcium channel blockers because they need the they need the forward flow of their systolic pumping ability in their heart to be able to get enough blood out into the periphery. And if you give calcium channel blockers during a bradycardia or heart failure or MI where the forward flow is already compromised, you might just push it over the edge and cause some decompensation, and they'll go into pulmonary edema. If someone has resistant hypertension, and say they have a disease like cons, where they have hyperaldosteronism, spironolactone can be a really good choice. Spironolactone's a diuretic, another diuretic, but it's an aldosterone antagonist. So it's convenient if someone happens to have hyperaldosteronism, and that's one of the big causes of resistant hypertension. And one last thing that I was told was that you shouldn't put NSAIDs and ACE inhibitors together because they can cause acute renal failure. So that's just another contraindication to remember. And of course there are probably other contraindications that I haven't mentioned, so like I said, this video isn't meant for people to be, and the videos following this aren't designed to teach people how to treat, but just as a kind of educational tool to help them along the way at medical school or whatever course you're doing. Okay, see you next time.